নাইম, 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 আমাকে শুনতে পাচ্ছো?
ভাই আমি শুনতেছি, আপনাকে বলেন।
মোল্লা ভাইকে ফোন দিছো? মোল্লা ভাইয়ের একটু ফোন দাও তো।
আমি এই ফোনটা দিয়ে ফোন দিতে পারবো না এখন। এই ফোন দিয়ে এখন ফোন দেওয়া যাবে না। পজিটিভ না?
আমি বলেছি আমারটা না, আসলে বুঝছেন না, তো আমার সবকিছু তৈরি করা আগে বলতেছে তো মানে আমার করার জন্য একটা পার্সেন্টেজ করে, ওর জন্য আমি একটা বলবো না। আপনারা যদি আপনি আগে থাকতে হবে, আপনাদের কিছুই লাগবে না, টাকা পয়সা কিছু লাগবে না, শুধুমাত্র আপনারা নামগুলো কি করতে হবে,
মিটিং গুলোতে জয়েন করবে।
এখানে একটা এটা মানে যে কোনো ভাই ওরা আমাকে নিয়ে দিবে আর কি থেকে।
Good evening, everyone.
রণদেব চলে আসছে। আসসালামু আলাইকুম রণদেব দা।
ওয়ালাইকুম আসসালাম, কেমন আছেন?
জি ভালো আছি। আমরা 5টা মিনিট লেটে শুরু করছি আর কি।
নিশ্চয়ই, কোনো অসুবিধা নেই।
আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম। মোল্লা ভাই এসেছেন?
Yes. Yes, alhamdulillah.
Thank you very much. Today is our international webinar meeting. I proceed my chairman, President Are Mullah. Please proceed me.
Thank you, Mr. Ali Ahad, Honorary General Secretary of Bangladesh Optometric, Bangladesh Optometric Academy Club. I request you to proceed the international webinar today. Thank you.
Thank you very much. Today is National Morning Day. I pay my condolence and respect to Bangabandhu and his family members who were martyred. Good morning, everybody. Today, our CME program is now started few minutes. Our chief keynote presenter, Kathy Stein, keynote presenter, Ranadev Banerjee, presenter, Zhuang Lim Liu, our our honorable chief guest, Professor Dr. Hassan Shohid Sarwardi sir. Now we go to our CME program. Please, Kathy ma'am, you start your presentation.
Assalamu alaikum.
Walaikum assalam wa
Walaikum assalam.
rahmatullahi wa barakatuh.
My presentation is about color vision, but from a different perspective. And it's about how we understand and communicate color. So we know that color plays a profound role in the way we act and react to our world. So we need to understand how we're communicating to others when we use certain colors. We need to understand how they react to color, and we need to understand how to use color to help them. And so there is a common language used for measuring and communicating color. And this also allows for accuracy when you want to reproduce a color. So I don't know how many of you are on Facebook, but in 2015, there was a meme that went around about a dress. And some people saw the dress as black and blue, and some people saw it as gold and white. And it turns out that they think the reason people saw it differently is that if we believe it was in sunlight, we were more likely to see it as white and gold. But if we thought the lighting was artificial, it looked more black and blue. So if we tend to get up early and go to bed early, we might see it more as white and gold. But if we're more of a night owl, if we tend to stay up late, where we're more in artificial light, we might see it as black and blue. So what is color? It's actually a characteristic of light, and it has to do with the light's spectral composition as well as its interaction with our eye. It's a psychophysical phenomenon, but the perception of color is subjective. Also, color can make us feel happy or sad. It influences our taste in food. And we often use color to judge a person's health, for example, their face color or the color of the retina. So we respond differently to light of different wavelengths. And that's how we get all the different aspects of color. They function best in bright light. And there are what are now called the S, M, and L cones. And S is short, which is about 2% of our cones. M is medium, which is about 1/3 of our cones. And the long wavelength is about 65%. And here you see the peak wavelengths for each one. There's not just one wavelength, there's a range. So the short is more in the blue end, the medium more in the green, the long in the red. So how do we express color? For example, what color is this apple? Is it red? Is it crimson? Is it bright red? Is it scarlet? So color names are not very helpful if you want to communicate color or if you want to reproduce color, because my idea of red and your idea of red may not be exactly the same. So for example, if I tell a lab I want a 15% blue tint, what color is a 15% blue tint? What also happens is that there are conditions that affect color. So here's the same apple, but the two halves, although they are the same color, look different because the light source is different. On one side is artificial light that is more yellow in color, and the other side is sunlight, which is more white in color. So if the light source is different, or the background behind it is different, or even the direction that you're facing it or the light is facing it can make a difference in how it looks. So it turns out that you may go to a farmer's market or to a market and the apple might look great because it's out there under sunlight. And then you get it home under artificial light and maybe it doesn't look quite as good. So every type of illumination, whether it's sunlight, if it's incandescent light, if it's fluorescent light, if it's some of the new LEDs, it will make the apple look different. So if you place it also in front of a dark background, it'll look more dull as opposed to a light background. And they call that the contrast effect. There are also directional differences. If you're looking at a car from a particular angle, it may appear brighter or darker depending on the car's paint, because paint can have high directional characteristics. Also, for accurate color communication, we then need to know the angle of viewing and the angle from which the object is illuminated. If they're not constant, two people are not going to see it the same way. What about us as the observer? Some people, in terms of their normal, or what we call normal color vision, may have a little bit of bias toward red or blue. We also know that there are eyesight changes with age. And so as the lens of the eye becomes somewhat cloudy, we know that people often don't see color as vividly or the same. We also know that because the lens absorbs a lot of blue, that if someone waits a long time to have cataract surgery, often after the surgery, everything will have kind of a layer of blue over it. What about size differences? If color covers a large area, it tends to appear brighter and a little bit more vivid than if it's a small area. So for example, if you're going to paint your house and you want to test a paint, do you want to take a color you're thinking of and make just a small square on a wall to check it out? Or do you want to paint at least a large square on the wall to have more of a sense of what it will look like when the entire wall is painted? It's called the area effect. So if you're selecting objects that are going to have a large area, like paint or wallpaper, and you only do it from a small sample or a swatch, you may even think you made a mistake when the color comes on the wall. I know in my house, I have a color in my kitchen that's called a certain blue, but at times, depending on the lighting in the room, it actually can look green. So when we describe color, we use a number of words. We use hue, we use saturation, we can use lightness, and we have what's called color temperature. So hue is really just another word for the color. So if you have a color wheel, you know that you have red or yellow or blue or green. The saturation, or what's often called chroma, is the intensity or the purity of the hue. Is it very vivid or is it very dull? So it changes outward from the center, meaning that if you're looking at a color grid, the color is most saturated near the center, and then as you go out toward the edges, you will get the same hue, but it will be not as saturated. And then you have a lightness value, or what's called value, which is the relative degree of black or white that's mixed with the hue. So for example, lemon as a color is a brighter yellow than the sort of yellow color of a grapefruit. And then you have color temperature, which we often describe as being warm or cool. So incandescent light is about 2500 Kelvin, and that is more yellow, whereas 5000 Kelvin or 6000 Kelvin is very white, much more like sunlight. Now, a lot of people are familiar with the Munsell color system, and of course the Munsell 100 hue test, but Munsell was an artist, and he wanted to devise a method of expressing color by using paper color chips that were different hue, different lightness, and different saturation. So as you can see, like we talked about, you have any given color expressed as a letter and a number in the Munsell system. And so you have hue that goes around the circle. You have that saturation that changes from the center to the outside. And then going up the center is the amount of black or white or value. So colorimeters are instruments that are used to quantify color. And they have scales that have been developed for both the hue and the lightness and the saturation. And then they turn those into numbers so that if you look at that chart at the bottom, there are different ways of expressing the color depending on the notation that you use. So every one of those, all 5 of those, are different ways of expressing the color of a red apple. So what are some of the features of a colorimeter? It has constant illumination and viewing angle, because we said that's how you're going to be able to make a similar comparison. There's a constant, in essence, observer. So the area effect and the contrast effect that we talked about are eliminated. And so the color difference from any target color is measured, and then it gets displayed in numerical form. The interesting thing is that the colorimeter's measurements really correlate quite well to human perception. In other words, they see color, or the instrument essentially sees color the way we do. So using a colorimeter can be important. For example, when you're using glass filters in phototherapy, or when you're checking tint color, especially when you have a patient who may be sensitive to small differences, or if you want the tint to perform in a certain way to protect a patient's vision. For example, if I have 2 lenses that are blue or look blue and even similar, and I test them, I may find that one has a little bit more red in it. Or when we say a lens blocks blue, how much blue does it really block, and where does it block it? Because they're not all the same. So it's kind of less reliable if we just look at it, because even the lighting in the room, our own age, maybe even our own physical condition, maybe a tint or something we have in our own glasses, eyeglasses, can make a difference. So the colorimeter doesn't lie. It correlates to human perception, and therefore can give us a more exact reading rather than just the way we think we see it. Now you also have what's called a spectrophotometer. And a spectrophotometer does give you full spectrum color measurement, but it does measure the reflectance off the object, the absorption of the light, and therefore gives you the transmittance at each wavelength. So it gives you more data than what we can observe. For example, it can tell you ultraviolet transmittance in sunglasses or in any lens. And it calculates the tri-stimulus values from this spectral reflectance data. And it happens to use YXY or this LAB nomenclature that you saw on the page where we had the 5 different ways of describing the red color. So what's the difference? Well, it turns out that some objects can have something called metamerism, and 2 colors can look identical under one type of lighting condition, but not another. So for example, 2 materials that you have may not match when you put them under fluorescent light, but they may appear to match if they're under an incandescent light source. So colorimeters can't identify and adjust for that metamerism, but spectrophotometers can. And so they can account for these apparent color differences caused by the light source and even the surface conditions. And they can offer multiple illuminant observer combinations. So they're more precise than a colorimeter. And they come as large instruments. They can come as smaller instruments. I think I have a picture coming up. I have a handheld spectrophotometer that I use. I also had one for a while that was made just for eyeglasses, and it had a little opening you could slide the eyeglasses into to see what the transmittance was of the eyeglasses. And I had patients who would come in and sometimes say that they could wear one pair of, for example, sunglasses and not another. And when you held them up and looked at them, they looked pretty close. But when you put them in the spectrophotometer, you would find that one had more gray and maybe one had more red, or one, I should say blue, more blue in it, and one had a little more red in it, and they were sensitive to that. So sometimes we cannot differentiate some colors from others, even if they are different. So there's a limit to the color discrimination of the eye. In a color diagram, you can have an area where you make these small ellipses, almost like small circles. And within those ellipses, that turns out to be the place where we cannot tell the difference. So what are the 4 characteristics of the color differentiation ability of the human eye? So if colors have a high saturation, the sensitivity to color difference is low. They're hard to tell apart. If the sensitivity to the color differences in the direction of hue varying, it may depend on the hue. It may depend on the color, how sensitive we are to telling differences in the color. The sensitivity to the color difference in the direction of the lightness can vary depending on the lightness. So if we are most sensitive around a lightness of what's called 50, if we go higher than that or lower than that, we have more difficulty telling the differences. And it turns out that for blue, the direction of the color discrimination threshold changes. And so therefore, that difference causes us to have a difference in how we perceive the color. And it's that mismatch that causes differences in the color difference evaluation between a color meter, like a colorimeter or a spectrophotometer, and the human eye. So even though we're pretty good, So how can we determine the color of an object? Well, you have to know the illumination, you have the object itself, you have the perspective of the observer. So, for example, when a color is independent of itself, like a light bulb, then that is the source color. So for source color, you only have two things: the spectral distribution of the light source and the perception of the observer.
Yeah.
But for object color, you have to evaluate the spectral distribution of the illuminant, because the color can appear different under different illuminants. And we already saw that if you have artificial light or sunlight, things do not look the same. But the illuminants are not required when the light source color is measured, because the color of the light source itself has to be determined. So a light source itself is a source color, but then when it's illuminating an object, it's going to change what the color of that object appears to be. And it turns out that with liquid crystal displays, it also matters on the viewing angle. And you know that computer screens, for example, have gotten better in the sense that if you looked directly at a computer screen and then you moved off to the side a little bit, or if someone was sitting in front of their screen and you came over next to them to also look at the screen, sometimes it was hard to see certain colors that might be on the screen. And they've gotten much better at that. But I can remember when there were screens where you would go just a little bit off center and things would really look significantly different. So why is color so important? Well, it communicates things invisibly. It affects our mood. It can actually affect our blood pressure. We can use it to bring down blood pressure. It can enhance learning. It turns out that the color in a classroom or a lecture hall can really make a difference. And certain colors grab our attention. You know that when something is bright red, it tends to grab your attention. Or if it's green, you may feel more comfortable because we're used to red meaning to stop or to know that there might be danger. And green can mean that it's an okay situation. So because color is so powerful in our external world, we also know that color can change how we perceive the world internally. And so we need to know how to measure and communicate color, especially when it can affect our treatment and our patients' lives. I know that here, people can purchase sunglasses, for example, that are different colors, or they can purchase non-prescription eyeglasses that can have a tint. Or at one time, just putting any kind of a tint on a pair of eyeglasses was popular. And sometimes that tint would be different from the top of the eyeglass to the bottom. You might make it more blue at the top, and then you might make it a little pinker at the part that's in front of your face. And I wonder, before we really thought about this so much, or when we should be thinking about it, if we aren't creating a situation that for some patients might actually be good, but for some patients might actually make them more irritable. So I think what I really want to be saying here, and I'll go back to that last slide, is that understanding color, understanding it from how we perceive our world, that it communicates invisibly, that it really can have an effect on our patients, so that, for example, in my exam room, I always keep color very basic and kind of a gray color. And I also am careful often what I wear to the office, especially not wearing anything striped, although many of us do, because when I work with brain injury patients especially, stripes can be very bothersome to them. So I do try to keep it pretty neutral. and anything that's sitting around your office. You know, what is the color? Is it bright and it attracts attention? Do you not want it to attract attention? Should it be fairly neutral so that patients will pay more attention to an object you have on a table, for example, that you really want them to pay attention to? And what about when we prescribe color? What about a tint? What about the color, the level of the tint? How is it helpful and where might it not be helpful? I know that I have prescribed some tinted lenses sometimes that seem to help patients that have color deficiency. And they're great during the day, but they're not so good at night. It makes it harder for them to see at night. And that's why sometimes we prescribe tints that are lighter for indoors and darker for outdoors. So understanding how color can affect our patients, how color in the environment can affect them and us, I think is something that we need to pay a little bit more attention to. We also know that we can use color therapeutically, and I do in syntonic phototherapy or optometric phototherapy, in that color can expand the visual field awareness for a patient. So we can do that in terms of lenses, and we can do that in terms of actual color therapy. So color is much more important than I think we sometimes give credit for. And that's really what I wanted to express. So thank you in color. And I hope this was helpful.
Any question?
Was there something in the chat? No. But if there are any questions, I'm happy to answer. You can ask them or put them in the chat. No, I think we're good.
Assalamu alaikum. How we detect the defect of color vision of human eye? How we detect the color vision
Of children,
of human?
I have a test here called Color Vision Testing Made Easy, and it has shapes. And we use it with children. It generally has a circle and a square. One card has a little star on it, but we have a demonstration card we can show first. And sometimes I'll give children either with their finger, but if they do their finger on it a lot, then the color may change over time. So I usually give them a little stick or something they can trace it with. And some of the cards, you can see a circle and a square, some only the square, some only a circle. And I use it with children. It's the same test we've used with Special Olympics. And all they have to, and sometimes I grab it even for adults, just when I want a quick test. Although I do have an AOHRR book here as well, and I have a D15 if I need to test more. But usually we're just looking for some basic color vision issues, more so that I can talk with a school or I can talk with an employer about when it will be a problem. But this color vision testing made easy works very, very well. And now they have it, I believe they have it for the computer. I know they have the one that's more like a standard Ishihara for the computer. In fact, they just sent me a link to one of the tests to test it out after I gave this lecture to another group. And so I have to look at that and see. But I know that in the past, I've seen some videos where someone tests color by just taking a bright blue or a bright red or a bright yellow and showing it to a child. Well, first of all, they have to know the name. And if they don't know the name or they mix up the name, how do you know that it's a color issue or they just don't know the name?
Right.
Okay, so I try to stay away from things where they have to name them, except if there's two things. So for example, if I use my Worth 4 dot and they tell me one color is red and the other color is blue, I don't care that it's green. As long as I know they can show me the difference,
Yeah.
that's fine. But if I add three things, then they might mix it up in a different way. 2 is
Right.
easy, 3 gets harder. So, and kids like to point to things, you know, they like to point, they like to trace. So when I give them the opportunity for that, but I work with a lot of significantly impaired special needs children, and many of them can do that test because I can have them just point. Or if they can't tell the square and the circle, I'll sometimes just ask them to point if there is a circle on the page. And the only problem I've had with the test is the large circle is on the page, but the background of each page are these very small circles. And sometimes when you say the word circle, they want to touch the background because everything to them is a circle. So sometimes I have to call it a ball or something different. But it works very, very well.
Ma'am, I have a question. As a researcher, what is the shortcut of finding color vision?
What is the what?
I say you, I am a researcher. I research the color
Yeah.
vision field, and who is detect now the eye problem 20 feet is now finger count, he yes or not? It is possible he cannot see. We say he have effective error. I say you, we found how easily shortcut of
How to
color vision
Well,
test.
I
detect whether
think-
there's a color vision deficiency or not, basically.
Yeah, so I think what we often say is the person has a color deficiency, but it certainly has different, what I'd call depth to it. I have some patients where really they can't tell almost any level of red or green, and others, if it's fairly saturated, will see it or at least tell the difference. I don't know if they're seeing it the same way I see it, but they have learned to tell the difference and can give it the correct name.
Yeah.
But when the saturation starts to decrease, they have more difficulty. And so I think when I'm talking with someone who doesn't understand color vision, all I want them to appreciate is that if they're using colored materials, for example, I can remember when I was a child that in school, they brought in a new reading program and it had different levels to it. And there was a box at the front of the room and you would go up and pick certain readers out of it. But every reader had a different color. So if someone would have had a color problem, maybe they wouldn't know what level they were supposed to pick. And so that's what I want them to appreciate it because it's not something you see. That's the issue with vision. You know, it's hidden. If I break my arm and I have a cast on my arm, you will think twice about asking me to do certain things. But if I have a color vision issue, you're not going to know that. And so especially today on the computer or when they write with certain colors in the front of a classroom or a lecture hall, it may be hard for someone to see all the information or differences in the information. For research purposes, I understand that we're going to talk about the different types of color vision deficiency, and maybe there are even levels within that. I'm not a color vision researcher, but the point I think of probably researching it is one, when and how does it affect our lives on a daily basis? You know, should, for example, here, there are certain professions you cannot become. You can't maybe be a fireman or a police officer if you can't see color. And also, does it help us understand how these things come about so that maybe at some point in time, we can do more to help those who have color deficiency. We know now that if you put a red lens on the eye or in front of the eye, it can be helpful for some. But I think we want to get to it more at the cellular or molecular level so that maybe we can turn it around for some people.
Any question, audience?
I think there are a couple of questions in the chat box.
Oh, in the chat. Yeah, let me pop the chat up. I just saw that. Why are neutral colors to be worn in front of brain injury patients? Well, when you've had a brain injury, you are often more sensitive, not necessarily to an individual color, but anything that is changing color like stripes. So black and white stripes or colored stripes tend to bother us. Partly, I think it's visual, partly that's something we know from the vestibular system. I mean, why do we try to elicit nystagmus with a striped drum or a striped cloth? So I know that patients are often, first of all, they're just sensitive to light often in general. So sometimes I have to turn off practically all the lights in the room because I like to work in a little bit of a lighted room. It's not bright, but it's not dark. But these are patients who come in literally with a pair of sunglasses and a hat and another hoodie over that. And they're looking down at the floor because they can't stand any light. So if they're that sensitive, I have to be careful of wearing things that are fairly neutral. The biggest thing is not to wear anything striped, horizontal or vertical. In fact, that's a test that we can do. If you show a patient a striped pattern and they go like, oh, get that away from me, many of those patients are actually prone to migraines. So I try to stay away from that. And it says, is it possible to perceive ultraviolet light? What are the exceptional visual qualities of tetrachromatic people? And is tetrachromism possible? I have heard that tetrachromism is possible. I don't know that I've ever met anyone, so I don't know very much about it. But generally, if we're talking about ultraviolet or we're talking about infrared, we don't see it. That's why even some of these devices now that use red and near infrared for pain, for example, it's become very big to use red for healing, that they tell you, one, if there's light leaking out from it at all, like if it's on your body, they want you to wear some kind of protective glasses because you don't know how much infrared you're getting and what the limit is that might be a problem. And also, whenever you're in a situation where there might be too much ultraviolet or too much infrared, either way, you want to wear something more protective. Now, I don't know how it is there. Here, there's a real push to wear sunglasses when it's bright outside and for them to have ultraviolet protection, because if they just have a color, they're not necessarily as protective if ultraviolet is a concern. I think we need some ultraviolet. I think some of us are less healthy because we're not getting at least some, but especially in lockdown for the last year and a half, where we've barely been outside, maybe. But my rule of thumb is if you're outside for 15 minutes, I wouldn't worry about it so much. But if you're going to be fishing on the water, if you're going to be outside all day, then you do want to wear something protective, partly also because if you get too bleached out, then when you come inside, you feel like you can't see, and you don't want people to be unsafe. But I think we do need some ultraviolet, and between wanting to wear sunscreen and sunglasses and the clothing that we tend to wear, most of us are probably not getting what we need, certainly for vitamin D, and that's why I take a supplement, because I'm not going to get enough outside. And it's not just the Northeast where I live, because we have winter and we have days when it's not as sunny, but even if you test people in some of the sunniest parts of the United States, you'll find a very high percentage of people who are low in vitamin D. So I recommend everybody take 2,000 to 5,000 units of vitamin D3 every day.
Thank you, ma'am. Any question?
I think that was all the questions.
Yeah. Okay, we go to the next session. Our chief guest is now our chief guest, Professor Dr. Hassan Shoaib Sarwardi sir, MBBS, FRCS Glasgow, MRC of London, XDO Dolbin, FAMS Vienna, FCPS IX, head of the department, Bangladesh Medical College, Dhaka, ex-principal, Uttara Adunik Medical College, Dhaka, chairman and chief consultant, Akhinahar Eye Hospital, Mohammadpur, Dhaka, Dean, School of Public Health and Life Science, University of South Asia, Dhaka, chief advisor, Bangladesh Optometric Academic Club. Please, sir, your valuable speech.
First, I should say sorry to you. I've been away because today is the death anniversary of the father of the nation, Bangabandhu Sheikh Mujibur Rahman. So my schedule was so heavy and busy with the other places, so I couldn't be here in time. So I'm sorry for that. So thank you very much. I don't know what speech I will say. Only Dr. Kathy's turn, he talks about color vision. Is it not so? The other speaker, they have talked about, they have finished their talking. Aliyahad.
Sir,
speaker ki boleche?
না শুধু ক্যাথিস্টেন ম্যাডাম বলছে কালার ভিশন নিয়ে।
Okay, then I'll follow the lecture of all the people and learn something from you people. I'm again say sorry to all of you that I've been busy with my heavy schedule today, as today is the day of the death of our father of the nation, Mujibur Rahman. So I am to attend so many meetings before coming over here. So thank you very much. Please continue.
Thank you, sir. Thank you very much. I request to our honorable keynote presenter, Ranadev Banerjee, sir, please.
Looks pretty scary, huh? Well, I chose this particular image because Aliyahad told me to speak on dry eye, and it's an excellent coincidence today that Bangladesh is basically mourning the father of their nation, Bangabandhu, and here in India we are celebrating our 75th Independence Day. So basically, we are having two parts of Bengal. One is crying and the other's eyes are dry, right? So it is a great opportunity for me to give an overview about dry eye over there. I considered this to be an like exclusively ophthalmological topic, but then when I pondered on it, I found that there's enough optometry in it as well. So let's go ahead with it. Okay, so to begin with, Charles Dickens said in his great novel, Great Expectations, that we need never be ashamed of our tears. Well, from perspective, we also do have great expectations from tears, because tears are clear liquids secreted by the lacrimal glands, right? And it's found in the eyes of all land mammals except goats and rabbits. Well, that's a news. The functions include lubricating the eyes, which we call basal tears, removing irritants, which is reflect tears, and obviously adding to the immunity, while also reacting as the body's natural pain response. Well, humans are the only mammals known to produce tears as a part of emotional response, and that's pretty interesting. Emotional secretion of tears may have several biological functions as well, by excreting stress-inducing hormones built out of emotional distress. And we know that tears are definitely made of water electrolytes, proteins, lipids, and mucins, that form layers on the surface of the eye. And definitely the composition varies depending on the type of the tear. So definitely we should not be ashamed of our tears, rather we should have great expectations out of it. So tears are made up of 3 layers, and this is basic optometry. All of us have learned this, that it contains certain mucus layers to adhere it to the surface of the eye. We have an aqueous layer, which gives it the watery content, and a lipid layer to prevent it from evaporating or spilling out. So tears are composed of not only water, salt, antibodies, lysozymes, and definitely it also differs depending on the kind of stimulant it has, because if it reacts to irritants, dust, or allergy, then the composition slightly varies. Well, emotional tears contain higher concentration of stress hormones like adrenocorticotropic hormones, as well as certain chemicals in it, which are natural painkillers like leucine enkephalin, which suggests that the emotional tears play a biological role in balancing stress hormone levels as well. So yes, definitely we need tears not only for the visual function, but also for a proper healthy well-being of ourselves. So here we just would like to have an insight to the composition of all these different layers. So lipid layers basically contains oils of different kinds. The secreted happens to be the Medomian glands, and very interestingly, if we see that the glands are located among the tarsal plates, and thus they deposit the tear fluid between the eye proper and the oil barriers of the lid. So it doesn't allow it to spill out. At the same time, due to the surface tension, it covers the surface in such a way that it also prevents evaporation very fast. Now, aqueous layer, I will not go through all the contents because you can see how huge the contents are, but definitely you can have a look at that. And the secretion happens from the lacrimal glands. The functions primarily is to promote spreading of the tear film, controlling infectious agents, and osmotic regulation. And then finally, when we go to the mucus layer, it contains mucins, which are primarily secreted by the conjunctival goblet cells, and it coats the cornea and provides a hydrophilic layer and allows for an even distribution of the tear film. So before we study about dry eye at all, it's very important that we understand what tears are, how it functions, and what it exactly does. So looking into an optometric importance of tear film, a healthy tear film, which is like about 10 micron thick and with a refractive index of 1.34, is one of the most important components for excellent vision. Obviously, we know that the eye contains 3 refractive interfaces, the tear film, cornea, and the lens. Now, out of 60 diopters of refractive power, approximately 40 diopters are derived from the air tear film interface and the cornea. So any disturbance of the air tear interface can have profound effects on vision. So if we see a patient whose vision is fluctuating or the refractive error tends to change very frequently, we might like to have a look whether that patient is suffering from some kind of dry eye or not. At the same time, if the tear film itself has all these 3 layers, now an impairment of any layer in the tear film is known to affect visual acuity, and for obvious reasons. If you have less of the aqueous layer, then the thickness of the tear film would reduce, and hence the refractivity would change. If you have more of mucus over there, then it might hinder the transmission of light, and like so. So here I have a certain demonstration in the right-hand side of my slide, where you can see the effective dioptric value, which is coming up on refraction. So we have air with a refractive index of 1, tear film with around a 1.34, and we see that about a 37.5 diopter approximately happens to be the effective power of the eye when we look only at the tear film. So we know the power of the cornea, but without the tear film, it really does not do a great job. So instead of just considering the health of the cornea and the transparency of the lens, we might as well look into the importance of the tear film as well, although it's only 10 micron thick. And definitely the disruption of the tear film is known to increase the anterior corneal higher order aberrations. Now, if you look at the image below, you're going to see that we are talking about a certain eye where you have breaks in the tear film. So what happens when the light actually tries to transmit through, when it passes through the area which has the tear film, the pattern of refraction is different. And when it hits the dry cornea, the pattern of refraction is completely different. Now, owing to the different refractive structures, there is going to be a hike in the chromatic aberrations as well, not to mention all the different kinds of 60 different kinds of higher order aberrations. And that gives rise to blurred vision. So it's a combination of all of these things taken together. So we might not look into refraction as a very plain spherical cylinder and so definitely it's a pretty complicated process. Now, if we try to understand dry eyes are a chronic lack of lubrication and moisture on the surface of the eye. Obviously, it's a chronic situation which is typically progressive in its condition, and it may not be completely curable. Obviously, it can be managed, but at the same time, the results of dry eyes range from subtle but constant eye irritation to significant inflammation at the same time. And it can be known as dry eye syndrome, dry eye disease, or simply dry eye. Now, there are certain alternative medical terms which are used to indicate dry eye, specifically with the condition that it is associated with. And obviously, these names help us to understand the seriousness of the condition. If we just call keratitis sicca, it means that it has this dryness along with the inflammation of the cornea, but the conjunctiva is pretty good over there. Keratoconjunctivitis sicca, which is like something which is like pasted in all the textbooks. Obviously, we are talking about cornea and conjunctiva both being involved over here. However, dysfunctional tear syndrome is also something which is not only about the poor quantity of the tears, but at the same time looking into the poor quality of the tears. So when we are trying to assess the quality of dry eye and plan a certain management regime, we need to not only see that whether tear secretion is happening properly, but we should also see that whether the quality of tear is good enough. So certain symptoms, and I think most of us are very well acquainted with it. Burning sensations, itchy eyes, aching sensation, heavy eyes, fatigued eyes, sore eyes, dryness sensation, obviously it's dry eye after all, red eyes, photophobia. Now, when we talk about photophobia, it can be linked post-LASIK and post-cataract surgery or pre-LASIK and pre-cataract surgery as well. So any kind of light sensitivity needs to be well looked after. Blurred vision, foreign body sensations, mucus in or around the eye is a very good sign of evaporative dry eye, leaving the mucus behind. So if you get a patient who says that I don't have any kind of irritation in the eye as such, but I get to see that a lot of mucus deposition is happening, it's not a mucopurulent discharge. There is no redness in the eye apparently, or very mild redness for that matter. You might also like to look into the possibility of dry eye and not only some kind of conjunctivitis. So discomfort when wearing contact lenses is definitely there. In fact, dry eyes happens to be one of the major reasons of the greatest dropout in contact lenses globally, if we see. And as odd as it may sound, watery eyes are also a symptom of dry eye. Now, some people might think that we are talking about dry eyes, but as the symptom is being suggested, it's watery eyes. How come? This is because dryness on the eye surface can sometimes lead to overproduction of the watery part of the protective mechanism, and this reflex tearing does not stay on the eye long enough to correct the eye condition. So what happens? You just get some reflex tears, again it dries up, and the vicious cycle goes on. Now, in addition to these symptoms, dry eyes can cause inflammation and sometimes permanent damage to the surface of the eye. It can also have an effect on the outcomes of LASIK and cataract surgery. So in case you are suggesting any patient to go for LASIK or for cataract surgery, and you are doing the workup prior to the surgery, it's very, very important to rule out dry eyes, because otherwise post-surgical results might not be very good looking. Well, the causes of dry eye. First of all, as on date, I would say a connected lifestyle. Most of us are in computers, smartphones, and whatnot. And with our eyes peeled, we are always looking over there, low blink rate, evaporation is obvious. So a connected lifestyle leads to greater tear evaporation and definitely increased pronouncement of the symptoms. Contact lenses, yes, I hate to say this, but contact lenses sometimes, especially the ones which are commonly dispensed without evaluating the health of the eyes, more or less, I would say that over-the-counter dispensing has a major role in aggravating dry eye situations nowadays. And that's why people eventually drop out from contact lenses. Aging is an obvious situation. As we age more, the eyes tend to become a bit more drier. Menopause in women. Indoor environment wherein we have this air conditioning or ceiling fans, which are like directly throwing the air in our eyes and eventually hastening up the evaporation rate. So even there are a lot of people, in fact, who say that I get dry eyes when I drive. And when you ask them, they will always say that the vent of the air conditioner is on and facing their faces. So yes, even these artificial situations can lead to transient dry eye. And outdoor environment wherein we have dry climates, high altitudes, dry or windy conditions can also increase the risks. Air travel. Well, I think Kathy would agree with me. When you travel a lot for delivering lectures and all these things, and when you come out of the aircrafts, yeah, we do feel this dryness in the eyes. And that's because of the extreme dry air condition inside the aircraft, which actually pulls out the moisture out of our eyes. Smoking, well, I do have this bad habit, but I do feel a bit of dryness sometimes, and I will not talk much on that. But health conditions, yes, certain situations like diabetes mellitus, thyroid associated conditions, a lot of autoimmune conditions like SLE, rheumatoid arthritis, Sjogren's syndrome can contribute to dry eye problems. A lot of medications, and obviously my medical colleagues would start scowling at me on this when we say health conditions and medications, but yeah, we complement each other. So many prescription and non-prescription medicines increase the risk of dry eyes, like antihistamines, antidepressants, certain blood pressure medications like beta blockers, diuretics, and birth control pills. Eyelid problems, a lot of eyelid problems, particularly blepharitis of all these kinds, lack of ophthalmos, these things can definitely complicate matters. So as an optometrist, it's definitely our priority to have a very close look at the entire eye and adnexa to rule out any possibility of underlying situations. LASIK and other corneal refractive surgeries can sometimes cause dry eye. So yeah, if we think that we have a patient who might have a regular complaint of dry eyes, we should be ideally thinking twice before recommending that patient to go for LASIK, however high the prescription is. So if you have dry eyes prior to LASIK, the eye doctor or whoever is prescribing may recommend a dry eye treatment before the procedure can be ensured. And nowadays, wearing a mask can also lead to dry eyes. Now, people would say that, how come? Well, when you wear a mask, especially to prevent yourself from getting COVID-19, the dry air which you're exhaling sometimes get forced out towards your eyes, and especially if you're wearing a pair of spectacles on top of that, it does not get an exit point, and it is definitely directed towards the eyes. Being a bit warm, it also makes the evaporation rate faster. And certain allergies can definitely cause dry eyes, and taking antihistamines for relieving those allergies can also cause dry eyes. So you see what a big vicious cycle we are in when we talk about dry eyes. Now, there are different categories of dry eyes, as we said, that if you find that the Medomian glands are not producing enough oil, so what happens? The aqueous layer of the tear film is more exposed and is prone to evaporate much faster. So we call that evaporative dry eye, and it's closely related with Medomian gland dysfunctions of different kinds. And also, sometimes you see the total volume of tear which is being created, particularly the aqueous layer, is very less. So we call those aqueous deficiency dry eyes. And the specific type of dry eye often determines the type of treatment that we are kind of giving. So certain, again, association with systemic diseases, Graves' disease can definitely cause ocular discomfort, and as well as this immune medicated lacrimal gland and Medomian gland dysfunctions leads to dry eyes from here. So while treating these conditions, we should know a little bit about the background of these conditions. I know that a lot of textbooks talks about these things, and when we study optometry, we literally just try to memorize the names. But if someone asks us what happens in a multiple sclerosis or what happens in a Graves' disease, most of us would say that, well, that's something for the doctors to do. And I would suggest for every optometrist who is learning or who is practicing to have at least some kind of knowledge about the basic identification of these conditions. If not, at least have a medical colleague of yours to converse with you, so that you can definitely give them a ring and share your concern that maybe this patient has this situation. What could be the signs and symptoms that I should look out for? As I said, multiple sclerosis is a demyelinating disease which can lead to severe dry eyes, and the patients may have limited ability to install even drops or perform lid hygiene properly. So punctal plugging and using humidifiers and in-office blepharitis therapies may be very crucial for these kinds of patients. Rosacea, if we see, patients with cutaneous rosacea can develop blepharitis, and they might be requiring oral azithromycin at some point, or they might require certain therapies like intense pulse light or intraductal Medomian gland probing to clear up their Medomian glands and have a proper secretion flow going on. Rosacea patients should also avoid any triggers such as, like stress, spicy food, alcohol, and excessive sun exposure. So a little modification in their general lifestyle can also relieve them of this condition to a great extent. Pediatric dry eye is again a matter of concern. Now this becomes a bit crucial because nowadays with all the online classes going on, you really cannot deduce that whether the child is having a dry eye due to overexposure to digital devices, or there can be situations of juvenile rheumatoid arthritis or juvenile onset of SLE, diabetes, vitamin A deficiency, or really Day syndrome. So it's always good to have a thorough history being taken, or at least probe in with certain very targeted questions to ask that whether do you have joint pains? Do you feel very weak at the end of the day? Or when you're working, do you feel a lot exhausted? So a thorough history might give you certain links to find the underlying conditions, and it not necessarily would be a connected lifestyle. So have a watchful eye out for that. And then certain systemic medications, which we have already discussed, like diuretics, beta blockers, antidepressants, antipsychotics, antihistamine, etc., can also exacerbate dry eye. So if we see that there is a history of the particular kind of drug done, and that may alleviate the condition. So it's not always that you come up with a case of dry eye and you start pouring in certain lubricating drops. There can be a lot of way around that. And well, there's a debated and controversial link to alcohol. Certain studies find that a lot of alcohol consumption is a risk factor for dry eyes, while others say it's not. So drink at your own leisure. That's what I can say. Okay, so investigations. Now, definitely, as I say, that medical and ocular history about all medications and certain underlying conditions would really help in diagnosing dry eye. Symptom questionnaires can really help. You can look at the blink rate. If you find that there's a very frequent blink rate, then it might raise an alarm. You might do a non-invasive TBUT or even a TBUT with fluorescein, or also you can have a tear stability and mammography done. But I'm not very sure that whether all these facilities are available in all the countries who are participating. Of course, the first world countries do have these things, but I doubt about the other ones. But still, these are possible. Osmolarity can be checked. Corneal and conjunctival staining with fluorescein and lissamine green can really give us an insight. And we can definitely do Sharma's or phenol red thread test also. And lead evaluation in a slit lamp will really help us. So here I have listed certain traditional tests and certain emerging tests for everyone to know that what could be the future in their respective countries and what is currently going on. So when you have symptoms and functional impact, that is the test objective. So you do certain questionnaires. When you want to test the tear volume, a Sharma's or a phenol red thread really happens to be the gold standard as of now. But yes, tear meniscus with anterior OCT and fluorophotometry is also upcoming. And this would be a bit expensive tests, but they're worth it. Well, tear film stability can be tested by invasive or non-invasive TBUT. Non-invasive TBUT is like getting into the trend nowadays, along with interferometry. When you want to have the tear clearance or the tear turnover rate, then fluorescein clearance, TFI, fluorophotometry will really help you. Also, there is some other way around. You can always drop a certain fluorescent stain in the eye and put, let's say, an earbud through the nose and see how soon the earbud gets the stain of the fluorescent. Well, now these are ways around where you can definitely practice in clinic when you don't have access to such high technologies, but this would really, really help you. Tear film composition can be checked using osmolarity, and nowadays new technologies with biomakers are coming up. Corneal evaluation, fluorescein is something which I really love doing, and epithelial thickness, confocal microscopy, thermography are certain new things which are coming up. Conjunctival evaluation with lissamine green and rose bengal are better than fluorescein staining because they give you a lot more data. But yeah, in certain cases which are extremely aggravated, biopsy, impression cytology, confocal microscopy are certain emerging tests. Lead evaluation, slit lamp is any day the gold standard for me to check any of these things. But yeah, nowadays mammography, lead viper, epitheliopathy, these kinds of tests are also emerging. And Sjogren syndrome has their regular serological test with a combination of signs and symptoms and biopsy in some cases. So these are the things which you might like to do while you are investigating for dry eye. And that will help us in certain differential diagnosis. Like we can definitely try to segregate whether the dry eye is because of aqueous deficiency or evaporative. If it is aqueous deficient, it might be due to Sjogren syndrome which can be primary or secondary, or non-Sjogren syndrome, which we might be more interested in as optometrists to see that whether it's due to lacrimal deficiency, lacrimal gland duct obstruction, reflex block, systemic drugs, what it is. And if it is evaporative, it can be intrinsic or extrinsic. Intrinsic meaning Medomian oil deficiency, disorders of the lid aperture, low blink rate, drug action, and extrinsic could be vitamin A deficiency, topical drug, including preservatives, contact lens wear, and certain ocular surface disease, including allergy. Now, how do we understand that what's going on exactly? And if you see the classification over here on the right-hand side, I'll just like to draw your attention to one particular area, that we have this aqueous deficient dry eye, increased evaporation dry eye, and decreased wettability dry eye. So we have certain target components which we would like to see. But on a very, very easy note, if we just look at a TBUT pattern, the breakup pattern in aqueous deficient dry eye would be like an area or a line emerging from the fluorescent stain. It would be random in case of increased evaporation dry eye, and it would look like a spot or a dimple when we are talking about decreased wettability of dry eye. So if you just see that looking into the pattern of that break in that fluorescent stain, it gives us a lot of insight as to what might be the situation behind it. So yes, I would say that these are worthy of experimenting and looking into in your clinical practice. So how do we do a TBUT? Well, this apparently looks like a child's play to us when we talk about the steps, but yes, there are students who are learning. So for them, I would say that if you would like to do it with fluorescent, so have your fluorescent strip, because in India and Bangladesh, mostly we don't use the 2% fluorescent drop. What we get is more of a 0.5% fluorescent strip, although anything can work over there. So you wet it down with like preservative-free saline solution. In some cases, people who anticipate that there can be certain erosions in the cornea or other things, they would like to put a drop of antibiotic or a lubricating drop over there as well. But saline solution is the best that I would recommend. Examine the eye under slit lamp with low magnification and broad beam covering the whole cornea, and switch to Chroma filter in slit lamp if you do have one. Ask the patient to blink once and keep the eyes open. Now, due to fluorescence, the tear film will appear green in color. Black spot indicating the dry area will appear after a few seconds or after each blink in some cases. Now, TBUT is the time interval between the last blink and the first appearance of the randomly distributed dry spots, of which we have already discussed. Now, if the patient blinks before 10 seconds, test must be again restarted. Taking 2 or more measurements and then calculating the average would give you a fair idea. Now, in case in your respective country, you are not allowed to use fluorescent, there is also a way around to that. Obviously, there are some pretty fancy machineries which can be used, but if you do have even a pretty simple manual keratometer, which I do have in my clinic, that would really work well. So you position the patient well over there, have your Myers on the cornea, ask the patient to blink, and then ask him to hold their eyelids and not to blink. So when you see that there's a distortion which starts appearing in the Myers on the cornea, you don't need to, really merge them or do anything. You just need to look at the Myers. That would tell you that, yes, now the tear film has started breaking off because the pattern of the Myers have changed. So all you need to do, whether you are using a fluorescent or whether you are using just your keratometer or any other thing that you're going over there. In fact, even if you don't have a keratometer and you just have a torch in your hand, and you have a placidose disc, that can also work fine enough if you have a good clinical eye. So you need to have a stopwatch handy. That's what I always do. I put on the stopwatch in my phone while doing these examinations, because that gives you an exact idea as to when you saw the break or when the patient blinked. Now, generally, TBUT value between 10 to 35 seconds are considered as normal. Anything which is less than 10 seconds is usually suspicious, but that is not a confirmatory test. Even though TBUT is under normal limit, if the ocular protection index is less than 1, dryness and discomfort can occur. Now, what is this ocular protection index? The interaction between the tear film breakup time and the blink interval. So basically what you do is like you divide the time for blink. So it's based on this idea that when your TBUT is normal, if the blink is too slow, it may cause breakage of the tear film due to increased evaporation. The ocular protection index can be calculated by dividing the tear breakup time by the interblink interval. So you have blinked once, and the second time when you blink, if you know that particular time frame and you divide it, so then you are going to get it. So I think it's getting a bit complicated. I will give you an example. Let us say that the interblink interval and the TBUT are same. So you have about, let us say, 15 seconds after which the fluorescent pattern has started breaking. And if you notice that the patient has also blinked after 15 seconds. So you divide 15 by 15, you get 1. So if that happens, it's good enough. But if it is not so, sometimes what happens that when we are staring at the computer screens, like not blink very frequently, and might as on the present day situation. And then you can definitely test for the volume of tears that's getting produced by using something called a Shermer's test. So what you do over here, you have a specially graduated paper, which is basically a filter paper being used as a blotting paper. Now you have a notch over there, which you basically put below your lower eyelid. Away from the cornea is always what I would suggest, because otherwise you would create some reflex lacrimation. So put it towards the edges over there. So if you have anything which is like going beyond 10, 15, 20, it's good enough. It's a normal tear production. Anything which is close to 10 or a little above 10, possible shortage of tears is there. And after 5 minutes, if you still see that it has not touched the 10 millimeter mark, you would like to be concerned on that. Now, aside to all these things, now here are some funny pictures which I would like to show you. And certain things which you might like to have, something which is called a bottom lamp, and that can be pretty portable. That would really help you to do carry out this examination. Now, this picture on the upper left-hand corner is what you're seeing, kind of a lamp, which emits the requisite energy, which can trigger the fluorescent reaction, the photochemical reaction with fluorescent basically. And if you really want to have the effects much more pronounced, I would like to this yellow looking filter, which is called a Ratten B12 filter, handy, because that will really make the colors pop out. And even the mild breaks which might be visible, as you can see here in picture B over here, there are certain mild breaks which are coming up. Those are also going to be very clear if you see it through the Ratten's B12 filter. Now, it's not only that you have to have it handheld, you can also use it in conjunction with slit lamp. The upper image over here is the non-invasive pattern where I was talking about using a keratometer. Now, if you see here on the left-hand side, all these Myers look pretty good, but here they look a bit like not very clear, right? It appears to have broken. So at these regions, you would definitely see that, yes, the break has started. And here I have a very lousy picture showing the Shermer's test being taken in, because the moment this particular person would lower their eyes, there would be reflex blinking. And this is, I have put it there intentionally so that you don't do this thing. Try to put it somewhere in the corners over here and you will get a more reliable reading. And then obviously here we have something which we really like to flaunt out, the slit lamp biomicroscope with the blue filter, the cobalt blue filter. And that's how you do this. Now, there are certain insights to systemic diseases which I would like to highlight, although this is not my real domain. But yeah, if you find dry eyes, it's a good idea to have tongue and ask that patient that, do you feel some dryness in the mouth as well? Because a sore, cracked tongue is suggestive of Sjogren's syndrome. So that might be very definitive, and you might be helping out a medical professional, a physician per se, with your diagnosis. So your referral really counts over here. You might also like to ask the patient that whether they feel a lot more thirsty. So the intake of water is very frequent and urination is very frequent. So they are suffering from polyuria and polydipsia. So that can be signs of diabetes mellitus. Now, if you do find that, then the common tests like Shermer's type 1 without anesthesia, TBUT, these things might not be very handy tests for you. You might like to go with some advanced tests like tear osmolarity for type 2 diabetes, In fact, a study comparing tear osmolarity with the common dry eye disease diagnostic tests in a patient in type 2 diabetes found out that osmolarity had a greater diagnostic accuracy than Sherman's test type 1, TBU, Rose Bengal, and fluorescence training. So these are certain red flags which you might like to see while you are undergoing your diagnostic tests. And yeah, definitely you would like to add on the dietary supplement with omega-3 fatty acids, etc., which are known to really help in these kinds of situations. So how do we manage it? A lot of discussion about how to diagnose and all these things. What is the management all about? Okay, so I'll give you 16 pointers on that. So artificial tears, eye drops, which are over-the-counter eye drops. You don't need to have a medical prescription to get those things. What you can really work on over here is try to look into the composition. Now, there are certain compositions available with over-the-counter artificial eye drops, which would really supplement the aqueous layer. And there are certain eye drops which helps in increasing the adhesiveness to your eyes. So if there is a mucin deficiency, that might help. If there is an evaporative situation, that might help. And also looking into the severity of the dry eye, you might like to look into the concentration of those kinds of things, because you have it all the way starting from drops going up to gels. So this thickness, which I would say in layman's terms, basically the concentration and the viscosity of those drugs would really help to assure you as to how long the effect would last. Obviously, the more viscous the thing is, the more it will hamper with your vision. So you might like to have a combination as well of the same composition. You don't want to mix compositions. So let us say you have a carboxymethyl cellulose. You might use it as a drop during the daytime, and you might use a carboxymethyl cellulose gel at night, so that while the patient is asleep, whatever the condition, it will keep the eyes moist enough and not aggravate the dry eye. Now, there are certain specific drugs which are prescription-only medications, which has been released by Allergan and some other companies. Now, Allergan calls it Restasis. Now, this not only lubricates the eye, but also tries to reduce the inflammation. It's important to know, however, that the effect is not immediate. So you would like to have your patients a bit more patient. So patience is a virtue anyway here. Now you must use the drop daily for a minimum of 90 days to experience the full benefit of it. Some people might experience burning eyes during the first few weeks of treatment. So you need to warn them beforehand. Now there is another similar drug which is called Zydra, and it goes in the same line of treatment. So you would like to have 2 applications per day for approximately around 12 hours apart. Steroid eye drops is something which I personally don't like to use a lot, but yes, it has been a gold standard in controlling inflammation over the years, and has a significant cause of dry eye also, and it has helped to reduce dry eyes also. So a very smart administration of steroids might also help, together with lubricating eye drops and drugs like Zydra or Restasis. Now you have certain things called Lacrisert coming from Bausch & Lomb, which are slowly release lubricants which are placed under the lower eyelid. Now it's very important over here that yes, it is going to release the lubricating solution slowly and have a very long period through which your eyes will not become dry. But if it is placed very close to the cornea, or if it is again placed in a wrong position, it might also cause certain abrasions on the cornea and complicate matters. So if you are prescribing these things, you got to be very careful about the process of administering it. So the explanation part has to be very good in clinics. Now, there are certain situations wherein you would like to use punctal plugs. Obviously, I understand in India and Bangladesh, you might have to do this in consultation with an ophthalmologist. But yeah, the entire idea is that you stop excessive drainage of the tear film from the lacrimal lake and thus retain it more over there. So there can be situations, as we have discussed previously, where you would like to have punctal plugs in. Meibomian gland expression or Meibomian gland probing is another concept which has been picking up nowadays a lot, where forcefully and in more invasive manner, you would like to express the solidified contents of the Meibomian glands and make them work fine again. So this can be a painful affair in some cases, but it's definitely a helpful affair. Warm compress is the best alternative which every optometrist can recommend, and this is something which is really good, because if you see, Meibomian glands and the oils coming out from there, if they freeze in, it's more like a candle wax. So if you are giving a warm compress, eventually they're going to melt out and they're going to get expressed. So you can have a warm compress. Now, warm and compress, both the terms over here are very important. You don't want to just give warmth to it, but you would also like to press it a little bit. That will help in expressing it out. So have a mirror in front of you, pull down your eye lids, look at the margins. If you see certain wax like stop points on your Meibomian gland openings, you might like to do this as well. Now, unfortunately, warm compress to work well, it has been noticed that the temperature has to be maintained somewhere around 108 degrees Fahrenheit, and you have to apply it for more than 10 minutes. So again, patience is a virtue. Now, then there are certain special apparatuses which are being used nowadays. One of them happens to be Lipid Flow, which is a thermal pulsation system. So a more high-tech system of the warm compress, I would say. You can see the picture over here, and it does exactly the same thing. It gives a proper heat and it compresses over there. The treatment takes around 12 minutes per eye, and it's definitely an in-clinic situation. So it expresses the clogged glands and thereby restores the correct balance of oils in the tear film and relieves dry eye syndrome. Now, here is again a high-tech instrument which is called the Intense Pulsed Light, or IPL. Well, IPL, as we understand it, is more of a cricket match that goes along, but this is something to do with the eyes. So it's not Indian Premier League. Okay, so it's intense pulse helps to resolve the dilated vessels associated with rosacea and relieve the associated inflammation that contributes to the dry eye syndrome. So it might be very helpful for some specific patients. Nutritional supplements, well, now after a long presentation in the way we feel a bit hungry, and here are certain good foods that would really help you to relieve yourself from dry eyes. And even simply drinking more water, which I have not been doing, might help to relieve dry eyes a lot. So yes, cod, these kinds of fishes. And if you are a pure vegetarian, then flaxseed oil could also be useful. The main funda is blink more often. Eye makeup, ladies, please pay attention over here. You don't want to have a lot of eye makeup lingering behind, because that might clog up your